السلام عليكم ورحمة الله وبركاته. أنا طبعا بتوجه بالشكر للأستاذ الدكتور سيد عبد الفتاح على الدعوة الكريمة، وأرجو إن أنا في آخر يوم أقدر أفيدكم بأي حاجة، لأن الموضوع كان من اختياري. وبعد ما سمعت الدكتور حسام وهو بيتكلم على إنه فوجئ بالرول بتاع الكيدني في الجلوكونيوجينيسيس، أنا قلت لا، المحاضرة ممكن يبقى لها رول. بسم الله. The role of the kidney، الموضوع بتاعنا kidney diabetes interplay، يعني الرول of kidney in diabetes، وبالتالي اخترناها في type 2 diabetes على اساس ان كلنا عارفين ان type 1 mainly insulin deficiency. The role of the kidney in glucose homeostasis in type 2 diabetes. Renal gluconeogenesis in the post-absorptive state. In the fasting or post-absorptive state in healthy individuals, the kidney contribute about 20% ل 25% of the glucose released into the circulation via gluconeogenesis، يعني من 15 إلى 55 جرام per day، with the liver responsible for the remainder via both glycogenolysis and gluconeogenesis. Renal gluconeogenesis occurs predominantly within proximal tubule cells in the renal cortex and is chiefly regulated by insulin and catecholamines. Insulin reduces renal gluconeogenesis directly and also reduces the availability of gluconeogenic substrates such as lactate, glutamine, or glycerol, thus reducing glucose release into the circulation. Adrenaline stimulate renal gluconeogenesis, stimulate renal glucose release, inhibit insulin secretion, increase supply of gluconeogenic substrate, and reduce renal glucose uptake. Renal gluconeogenesis in the post-absorptive state in patients with type 2 diabetes. In patients with type 2 diabetes, both renal and hepatic glucose release are increased. As a result of increased gluconeogenesis, the relative increase in renal gluconeogenesis is thought to be substantially greater than in hepatic gluconeogenesis, about 300% versus 30% by the liver. Renal glycogenolysis is minimal in healthy individuals, but may play a role in increased renal glucose release in patients with type 2 diabetes due to accumulation of glycogen in diabetic kidney. ده كان في البوست absorptive state. Renal glucose release in the postprandial state. Renal gluconeogenesis increased during the postprandial state relative to post-absorptive state. Studies using stable isotope to estimate renal glucose balance have shown renal glucose release increase more than twofold during the 4 to 5 hours postprandial period. It is thought that this increase in renal glucose release allow for repletion of hepatic glycogen stores by permitting suppression of hepatic glucose release. The mechanism for this are not actually known, but may include the postprandial increase in lactate and amino acids that are precursor for gluconeogenesis, as well as an increase in sympathetic nervous system activity. Indeed, renal glucose production account for about 60% of endogenous glucose release during the postprandial period, 4 to 6 hours after meal. The increase in glucose release over the 4 to 5 hours postprandial period has been shown to be roughly about 30% higher, and حوالي 100 جرام versus 70 جرام in patients with type 2 diabetes compared with healthy individual, primarily due to increased endogenous glucose release. It is estimated that 40% of the increase in endogenous glucose release occurs via the kidney, Renal glucose release is regulated by insulin. Thus, as insulin resistance increases, suppression of renal glucose release decreases. An additional explanation may be an increase in renal glucose reabsorption due to upregulation of the renal glucose transporters. Renal glucose transport. The kidney plays a key role in glucose conservation, filtering about 160 إلى 180 gram of glucose per day in healthy individuals, which is all reabsorbed within the proximal tubule. Glucose reabsorption occurs via both sodium glucose cotransporter and glucose transporters. The energy for sodium glucose transporter mediated active transport of glucose against its concentration gradient across the cell membrane is derived from the sodium electromechanical potential gradient. This is maintained by the transport of intracellular sodium ion into the blood via sodium-potassium adenosine triphosphate pump situated in the basolateral membrane. Clots bind glucose, inducing the conformational change, and glucose is passively transported across the cell membrane from the intracellular compartment into the plasma. SGL sodium glucose طبعا active transport, الجلوت passive transport. Within the proximal renal tubule, 2K subtypes of SGL2 sodium glucose transporter and GLUT are responsible for glucose reabsorption and are expressed at the luminal brush border and the basolateral membrane of the epithelial cells respectively. SGLT2 is a high capacity, low affinity co-transporter that is responsible for the majority of renal glucose reabsorption. وبالتالي الدراجز اللي موجوده معظمها شغال على الاس جي ال 2 لانها هاي كاباسيتي اند لو افينيتي. Coupling the active transport of sodium and glucose in 1:1 ratio within the early proximal tubule. Glucose is then reabsorbed into the circulation via GLUT2. Any remaining glucose is reabsorbed by SGL2-1, a high affinity transporter expressed within the distal proximal tubule, and then reabsorbed into the blood via GLUT1. ده البرزنتيشن بتاعه الشكل بتاع البراش بوردرز والانتريومينال بوردر. ده الدياجرام بيوضح لنا ان اي البلاد جلوكوز اقل من 180 بيبقى توتالي ري ابزوربد، اكتر من كده بيظهر عندنا في اليورين. There are some genetic defects in renal glucose handling. A specific mutation in SGLT2 gene can result in naturally occurring glucosuria. Glucose galactose malabsorption is a rare condition caused by mutation of SGLT1 leading to وده الرول بتاع GIT leading to malabsorption of these sugars due to a failure of the gastrointestinal epithelial cells to accumulate sugar across the brush border membrane. This results in gastrointestinal symptoms such as diarrhea and dehydration presenting in the neonatal period. Treatment requires removal of glucose and galactose, which is also transported by SGLT1 from the diet. Glucosuria in individuals with glucose galactose mutation is typically absent or mild, consistent with the minor role of SGLT1 in renal glucose reabsorption. ده اللي بيوضح لنا الجينيتك ديفكت الموجود. Familial renal glucosuria is a rare autosomal recessive renal disorder that results from mutation in SLC5 E2 gene coding for sodium glucose transporter 2. In the majority of cases, heterozygous is characterized by glucosuria of 0 to 10 gram per day at normal plasma glucose concentration in the absence of renal tubular dysfunction. Familial renal glucosuria is generally asymptomatic and considered to be a benign condition. Homozygous one may result in glucosuria of up to 200 gram per day, but is rarely described. However, available data from familial with homozygous familial renal glucosuria indicate that these individuals are asymptomatic with no history of polyuria, polydipsia, renal disease, or increased frequency of urinary tract infection. ده كان الرول بتاع الكدني في الديابيتس، واعتقد ان ده يعني الجزء البيزك في المحاضره. Diabetic kidney الجزء الثاني اللي هو الافكشن of diabetes on the kidney. Diabetic kidney disease is a progressive increase in proteinuria in people with long-standing diabetes, followed by declining function, which can eventually lead to end-stage renal disease. ده الستيجز بتاع النفروباثي، نورمال مفيش البومينوريا، بعدين مايلد البومينوريا والاوفرت نفروباثي. CKD diabetes طبعا الاي سي ار هو اللاند مارك بتاعتنا. chronic kidney disease checklist screen with random urine albumin creatinine ratio and serum creatinine for estimated glomerular filtration rate at diagnosis and then annually. Diagnosis with repeat confirmed ACR, delay onset or progression with glycemic and blood pressure control, prevent complications with dose adjustment. people with diabetes ده بيبين لنا الريسك بتاع الكرونيك كيدني ديسيز في البيشنت with diabetes. Pathological lesions of diabetic kidney disease. The normal healthy glomerulus include affluent arteriole, capillary loop, endothelial cells, basement membrane, podocyte, parietal epithelial cells. All these are affected in diabetes. Diabetic glomerulus display arterial hyalinosis, mesangial expansion and collagen deposition, basement membrane thickening, podocyte loss and hypertrophy, albuminuria, tubular epithelial atrophy, accumulation of activated myofibroblast and matrix, influx of inflammatory cells. Diabetic neuropathy أو نفروباثي بيبتدي الحالة ب أول حاجة long standing hyperglycemia والأذر فاكتورز سواء كان immunogenic أو epigenetic وجينيتك فاكتورز non-enzymatic glycation of protein البوليول باثواي والاوكسيديتيف ستريس على النيرف والاندوثيليوم والميزانجال والجلوميرولار والريتينال سيلز يبقى عندي الكومبليكيشن دايابيتيك نفروباثي ريتينوباثي ونيوروباثي. ده الراس سيستم اكتيفيشن اوف دايابيتيك نفروباثي. sympathetic stimulation hypotension decrease the sodium delivery على الكدني يحصل فيه activation renin angiotensin system. Screening and diagnosis. Screening for diabetic nephropathy must be initiated at time of diagnosis. Type 1 من أول زيارة بعد ما شخصنا العيان يجب إن في البداية نطلب ال ECR مباشرة. ده يختلف طبعا عن Type 2 عن Type 1 diabetes اللي هو بنبدأ بعد 5 سنين. Screening for diabetic nephropathy must be initiated at the time of diagnosis in patient with type 2. For patient with type 1 diabetes, the first screening has been recommended at 5 years after diagnosis. Screen annually when no transient causes of albuminuria or low estimated GFR are present, and when acute kidney injury or non-diabetic kidney disease is not suspected. Type 1 diabetes annually in post-pubertal individual with duration of diabetes more than 5 years. Type 2 diabetes at diagnosis and annually order random urine ECR and serum creatinine for estimated GFR. Potential causes of transient albuminuria, recent major exercise, urinary tract infection, febrile illnesses, decompensated congestive heart failure, menstruation, acute severe elevation of blood glucose, acute severe elevation in blood pressure. ده بس للملاحظة ما بناخدش من أول قراءة لازم نعيد ال ECR at least twice or thrice ويكون في 1 month in between. شكراً.